You're listening to Conferences Online Allergy from Children's Mercy Hospital in Kansas City, Missouri. Today is August 11th, 2023. Our topic today is pulmonary function testing in children. Our presenter is Dr. Chris Oermann. He is the Division Director of Allergy, Immunology, Pulmonary, and Sleep Medicine at Children's Mercy Hospital in Kansas City, Missouri.
On August 11th. We have Dr. Christopher Oermann. He is our division director here at Children's Mercy, Kansas City, in the division of Allergy, Immunology, Pulmonary, and Sleep Medicine. World's longest division title, I think. He's going to be talking today about pulmonary function testing in children. Thanks, Dr. Oermann.
Thanks, Chris. Big group, and as disclosures, I'm not an allergist, an immunologist, or a sleep medicine physician. I'm an old-fashioned pulmonologist. So I appreciate the opportunity to talk to you guys today. So I'm going to review pulmonary function testing in kids. So just a brief outline of what we're going to do today. We're going to do a little bit of a review about anatomy and physiology, then talk specifically about pulmonary function testing, focusing on the 5 W's and probably the more important H, which is how pulmonary function testing is done. Spend a fair amount of time talking about spirometry, a little bit of time talking about bronchoprovocation studies, and then if there's time, a little bit of this and that to fill the hour. So starting with anatomy and physiology, respiratory tract is divided up into upper and lower portions. The upper portion is comprised primarily of the pharynx, which is subdivided into nasopharynx and oropharynx. Some people will also talk about the hypopharynx or the laryngopharynx. For me, I think it's easier just to talk about everything from the level of the epiglottis to the cricoid ring as the larynx, and kind of separate that out from upper structures. In the lower respiratory tract, you've got conducting airways, which include the trachea, bronchi, and bronchioles, and then what's called the acinus, which is where gas exchange occurs, and that includes respiratory bronchioles, alveolar ducts, and then the alveolar sacs and alveoli themselves. The upper respiratory tract. The primary functions of the upper respiratory tract is warming, humidification, and filtration of environmental air, which can be both cold, dry, and full of nasty stuff. So this upper respiratory portion of the respiratory tract is really important in maintaining hygiene in the lower respiratory tract. The other important functions are phonation as well as glottic closure for coughing and exertion. And then the lower respiratory tract, the trachea is considered generation 0. It is lined by very classic respiratory epithelium, which is ciliated, pseudostratified columnar epithelium. There are cartilaginous rings throughout the trachea with a cartilaginous anterior portion and then a floppy smooth muscle portion in the back. There are lots of glands throughout the trachea as well. As we get down into the bronchi here, generations 1 through 11, you see the same respiratory epithelium, but instead of these C-shaped cartilage rings, you develop cartilage plates throughout the lower airways. You see a lot of smooth muscle throughout, as well as a lot of glands, including submucosal and other secretory cells. And then finally, when you get down to the bronchial level, these are generations 12 through 17, you transition from that ciliated pseudostratified columnar epithelium to a more cuboidal type cell that is also ciliated. You lose cartilage, and the lower airways are very, very floppy. And you have decreasing smooth muscle as well as decreasing prevalence of glands and other secretory cells. By the time you get down to the level of the respiratory bronchioles, which are depicted here, where you have small airways that actually have individual alveoli attached, you have that same cuboidal epithelium, but significantly decreased amounts of smooth muscle, and not much else going on. And then the alveolar ducts, you have more of the same, with non-ciliated epithelium, so a transition from cilia to no cilia there, but relatively cuboidal cells and really minimal smooth muscle. And then the alveoli themselves, this is the alveolar part, and this is the capillary part. You've got these type 1 pneumocytes, which are squamous cells, large, flat cells with very little cellular activity. That's where the bulk of the gas exchange occurs. There are only 40% of the cell numbers in the alveoli, but 90% of the surface area within the alveoli themselves. And then we have these very metabolically active type 2 cells, which most importantly produce surfactant, which is essential for lung function. They're 60% of the cell numbers, but again, only 5 to 10% of the actual surface area. And then within the alveoli, you have random alveolar macrophages wandering around. So segueing to pulmonary function testing, focusing on the 5 W's that I had mentioned initially. The first W is who can or should undergo pulmonary function testing. And one of the considerations is age. And on a regular basis, I will have medical students or residents who are rotating through our clinic say, you can't diagnose asthma in kids that are less than 6 or 8 or 10 because they can't perform pulmonary function testing until they're that age. So correction number one is that I can diagnose asthma in anybody I want to, regardless of their age. It is not absolutely dependent on spirometry. The other part of it is that trained respiratory therapists and pulmonary function technicians that provide care for kids all day, every day, can get very reliable, accurate pulmonary function testing on kids as young as 4 years of age. More sophisticated testing like lung volume testing, kids typically do need to be older, but really we test most kids 4 and above in our pulmonary function laboratory. The other part of who is the kids that have different types of disease processes, certainly obstructive diseases like asthma, cystic fibrosis, chronic lung disease of prematurity. Pulmonary function testing is appropriate. Restrictive diseases like Duchenne muscular dystrophy, Becker muscular dystrophy, Nemelin-Rod myopathy, as well as thoracic cage diseases like severe scoliosis. Pulmonary function testing is necessary and a critical part of evaluation of these kids. We in pulmonary see a host of interstitial lung diseases as well, where pulmonary function testing is important. Neuroendocrine cell hyperplasia of immune and rheumatic diseases where you have an interstitial process that impairs lung function, and then some vascular diseases as well. So why should pulmonary function testing be performed? There are a lot of reasons why pulmonary function testing is indicated and helpful. First and foremost, to diagnose disease. So you can characterize diseases as obstructive versus restrictive versus interstitial, but also to characterize the severity of disease. So 2 important parts of the same function. It's also important to assess response to therapy, whether it's bronchodilator responsiveness acutely or response to inhaled corticosteroids for long-term management of asthma. Pulmonary function testing allows us to monitor response to those therapies. Importantly, and something we often forget about, is that it's also very helpful in monitoring adverse effects of other therapies. Again, in our clinic, we see lots of kids referred from hematology oncology who have had chemotherapy that can cause lung disease as well as radiation therapy. So we see those kids at baseline and monitor their lung function throughout the therapy to make sure that we recognize any therapy-related adverse events related to lung function. More in the adult world than in the pediatric world, there are a lot of occupation and environmental injuries that can be associated with lung disease, and people are frequently asked to evaluate people for workers' compensation, insurance purposes, lots of reasons. So perioperative risk assessment, those environmental and occupational reasons, and then recreational risks such as, scuba diving and skydiving and mountain climbing can have relevance in terms of pulmonary function testing as well. I alluded to observing the natural history of disease. This is really important more for progressive diseases like cystic fibrosis than asthma, for example. But again, it's important to monitor asthmatics long term to make sure they don't have progressive disease that ends in fibrosis and fixed obstruction. And then finally, and maybe more importantly these days, is that routine pulmonary function testing is really essential in patients being able to participate in healthcare and co-manage their disease. And the more they know, the more they are able to engage in co-management and self-management of their disease. So when should pulmonary function testing be performed? I already talked a little bit about diagnosis to document both the presence of the disease as well as the character of the disease, as well as severity of the disease. We will do pulmonary function testing every time we see a child with established lung disease in clinic, but also it's important when there are exacerbations of chronic disease, whether it's cystic fibrosis or asthma. We like to know how low their lung function drops, as well as whether or not towards the end of therapy they're regaining their baseline lung function. And then routine surveillance, again, we do this in clinic, but an important part of this more recently is the use of home spirometry, and I'll talk more about that in just a second. Where should spirometry be performed or pulmonary function testing? The American Thoracic Society, which is ATS, and European Respiratory Society, which is ERS, have developed guidelines for all aspects of pulmonary function testing. An important consideration for us is adult versus pediatric facilities. And we regularly see kids that are referred to our clinics for evaluation because they have severe problems on pulmonary function testing. More often than not, the testing has been done in adult facilities where people are not really familiar with kids. They're not good at coaching kids, and they're not good at getting good, again, accurate, reliable pulmonary function testing data from kids. So the thing to remember is that adult laboratories really are not very good at testing children. So unless you're testing kids and working with kids all day, every day, you have to kind of take those results with a grain of salt. The last reason, or the last discussion, I guess, is sort of general versus subspecialty care settings for home spirometry and home spirometry. There are a number of pulmonologists, at least, that believe that pulmonary function testing, or at least spirometry, should be available in every general care office in the country, for the reasons that I talked about, is self-management and early identification of exacerbations and those types of reasons. The problem is that you have to maintain the equipment, which is problematic, but more importantly is the people performing the testing have to maintain proficiency and credentialing, and that's a bigger task than simply maintaining equipment. So I don't think the jury is back yet on whether or not we need to be doing pulmonary function testing, or at least spirometry, everywhere in the country and in primary care settings, but that discussion is going on. And then I talked about home spirometry just briefly. It is really important in some populations, like post-transplant populations, but also became important during the pandemic when most laboratories were temporarily shut down and clinics were shut down, and you were really limited to doing home assessments through telemedicine. And a lot of home spirometers went out during those years. We're now really back to normal. But there are certainly situations where home spirometry is very, very handy. So finally, the what, and people will often talk about pulmonary function testing and spirometry synonymously, and I beg people not to do that, because pulmonary function testing is a really big bucket that includes spirometry, but a lot of other things as well. If we're talking about just spirometry, even that is not just spirometry, because there's pre-post spirometry. There are bronchoprovocation testing that also is part of that spirometry. And in our lab, we do a lot more than that. We do lung volume measurements, we measure diffusion capacity, and then there are a whole host of sort of related pulmonary function testing tests of respiratory muscle strength, airway resistance and compliance, called lung clearance index that we use a lot in cystic fibrosis, measures of oxygenation, acid-base balance, sleep studies or polysomnography, and exercise physiology. So pulmonary function testing is a lot of things, not just spirometry. There's a little table that sort of talks about the types of testing that is done for specific disease processes on the right, as well as the part of respiration that you're trying to assess on the left. And these are in your slides that you were given, so you don't need to memorize that or go through it right now. So finally, the big H in that series of W's is how should pulmonary function testing be performed? And again, the ATS, ERS have combined guidelines that address most aspects of pulmonary function testing. And the guidelines are applied to both children as well as adults. And they have standards for performing pulmonary function testing, standards for the reports, as well as standards for interpretation. So the technical standards for performing spirometry were published in 2019. I am not going to read this slide. The guideline provides lots of painstaking or painful details about what all is involved. They go on, I think, for about 19 pages. One of the things they do talk about is the person performing the testing, and I will reiterate again, you really need people that work with kids all day, every day, to really reliably do pulmonary function testing in kids. The guidelines also talk at length about what makes a good FVC or FEV1 maneuver. So it's a forced expiratory maneuver that gives you the FVC and the FEV1, lots and lots of details. They also talk about the reported values, but they focus more on those in the interpretation guidelines rather than the technical guidelines. They provide large, long lists of indications and contraindications to doing pulmonary function testing. Most of this we've already gone over, but one thing that I will point out down here at the bottom of this list on the left is research and clinical trials. This is really an important part of what we do in academic settings. In allergy and immunology, there are lots of clinical trials of asthma medications that have been completed over the years. We do some asthma trials in pulmonary as well, lots of CF trials, as well as some interstitial lung diseases and other processes. So in academic medicine, the research and clinical trials is really an important part of this as well. So the ATS-ERS standard for reports came out in 2017, and there was a lot that went into this particular guideline for a number of different reasons. Prior to this guideline coming out, most pulmonary function laboratories used either equations for percent predicted that they had developed themselves, or one of a dozen or so other equations that were out there. Before 2017, there was an effort called the Global Lung Initiative to standardize pulmonary function testing throughout the world so that you can compare studies done at Children's Mercy in Kansas City with those done at Great Ormond Street in London, or something done in Tokyo. So the result is that this GLI equation came out, and when that was pushed forward, they also developed standardized reports that would include those GLI equations and results. So kind of a major change in what we did when this came out in 2017. So the current guidelines include demographic information, age, sex, height, weight, ethnicity, and again, these GLI equations are specified. They specify that the only important things to report in spirometry is FVC, FEV1, the ratio, as well as FET, which is forced expiratory time in seconds. The other big change was moving towards the use of Z-scores to determine normal as well as severity of disease versus the historic percent predicted. And I'll talk more about all of these. They recommend grading the quality of the maneuvers by the therapist or technician doing the studies. And then they felt strongly that the volume time curves, which are down here, as well as the flow volume loops, be included in these reports. So this is sort of the standard report that they recommended, and the one that we've adopted here at Children's Mercy. So the other standard that was produced was 2021 for interpretation of spirometry. And I'm not going to go through this other than to mention again that these GLI equations are the ones that should be used worldwide for interpretation. Other couple of things worth mentioning. Again, historically, we had used percent predicted of 80% and above for FVC and FEV1 as determining what's normal and abnormal. And the current guidelines really rely more on Z-score. So a Z-score of plus or minus 1.65 differentiates normal versus abnormal results. Again, they're using Z-scores for a 3-tier severity scale with mild disease, moderate disease, and then severe disease based on the Z-score. And again, this compares to historically, it had been divided up into 5 different severity levels, which was, quite frankly, a little bit of overkill, but was again based on percent predicted. So we've got Z-scores for normal, we've got Z-scores for severity of disease. And then we also changed what was the definition of bronchodilator responsiveness and went to a 10% change in the percent change relative to an individual's predicted value. So it's kind of complicated as opposed to historically we just used 12.5% change in FEV1 percent predicted. So a number of big changes in what the ATS ERS was recommending. A lot of it revolving around the use of these Z-scores. So talking briefly about spirometry in general, everything sort of boils down to what's called a spirogram, which we really don't see much of anymore, but I think it's important to understand as background. So if you think about normal breathing cycle, you take tidal breaths in and out, and tidal volume is the amount of air that's moved during that. After a normal inhalation, you can take in more air, which is called the inspiratory reserve volume. At the end of a regular respiratory cycle, you can blow out more air, which is called the expiratory reserve volume. And that's the total amount of movable air. But when you've finished exhaling as much as you can, your lungs aren't, deflated like flat balloons. There's still air in there. That's called the residual volume. So these 4 volumes are building blocks, different ways to come up with capacities. So all of the movable air is the forced vital capacity, and then the total lung capacity is the FVC plus the residual volume. Looking at these a little bit differently, if this is normal, we see a decrease kind of across the board, typically proportionally, in restrictive lung disease, whereas obstructive lung disease, you can actually have increased total lung capacities, even though your forced vital capacity and other volumes have been decreased. And then, again, another way of looking at this is if these are normal ratios for inspiratory reserve, tidal volume, expiratory reserve, and residual volume, you have significantly increased residual volumes with obstructive disease, and as a result, your total lung capacity can be increased despite significant drops in your vital capacity. And the restrictive disease, on the other hand, everything is just compressed and smaller. Another way of looking at the volume time curves that the ATS talked about, again, this is a normal looking volume time curve. With restrictive diseases, you have decreases in your forced vital capacity and your FEV1, but they are relatively proportionate to a normal curve. Whereas with obstructive diseases, you have significantly decreased FEV1 out of proportion to the decrease in the FVC. And as a result, we have these trends over here. So your normal ratio is typically 0.8 to 0.85. Obstructive diseases, we have marked decrease in FVC, but an even bigger decrease in FEV1. And as a result, the FEV1 to FVC ratio is significantly reduced. So less than 80% ratio is considered indicative of an obstructive process. And as I said, total lung capacity can actually be increased because of the marked increase in the residual volumes. With restrictive diseases, we see a more pronounced drop in FVC with a relatively well-maintained FEV1, and therefore the ratio goes up. So typically, a ratio more than 90% isn't suggestive of a restrictive process. But in order to really diagnose restriction, you have to do lung volumes. And again, the total lung capacity with restrictive diseases is always significantly decreased. So flow volume loops are sort of the heart of modern spirometry and the interpretation that we do. There are inspiratory loops, which are below the x-axis, and then the expiratory or exhalational loops, which are above the x-axis. And there's lots and lots of information in here. Important things to remember, again, this is flow and this is volume here. So the highest volume at the end of flow is your FVC. The other thing to remember is that we have these FEF values through here. FEF is forced expiratory flow at 25, 50, and 75% of the forced vital capacity. And this becomes important, as I'll explain in just a second. So this is the report that we use at Children's Mercy, and it really very closely follows that ATS recommendation. So this is the whole report, and then I divided it up into portions over here. So you see demographic information up at the top. You see tabular representation of FVC, FEV1, the ratio, and FET, which are the only things that the ATS wants to see. We have a figure that demonstrates those same things. And again, we've got z-scores here as well as z-scores here. And then we've got the requested volume time curve and then the flow volume loops. So looking at these in a little more detail, information that's included is height, age, sex, and race. And those four variables get plugged into the GLI equation down here. And that's what's used to generate the percent predicteds as well as the z-scores. The other thing that's on here is the quality grade that was recommended in the reports. And again, the volume time curves and the flow volume loops. The other thing that we see in our reports, although it's several pages in, are all of the flow volume loops that are generated by the patient. And I think these are important for two reasons. Spirometry is only as good as the technician, but also it's only as good as the effort and technique of the patient who's doing the forced expiratory maneuvers. And what you like to see is a long exhalation, typically at least 6 seconds in adults. 3 seconds is considered okay in kids less than 10, although I still like to see a longer exhalation to really consider the efforts reliable. The other thing is you want to see reproducibility of these curves, and most of these curves are right on top of each other. There are a couple that are a little wonky, but good reproducibility. So this is, at least on the surface, a good, reliable study that you can interpret with some confidence. We don't typically pay as much attention to the inspiratory loops because they're not as reproducible. So this is looking at those same things in a little more detail. Again, FVC, FEV1, the ratio, and then the forced expiratory time. Focus on the z-scores, as well as continuing to provide the percent predicted values for old timers that don't like newfangled notions like z-scores. So we've got normal values here, and then our ratio of FEV1 to FVC right here, which is normal as well. The same information provided graphically. Green is good, red is bad. And then we've got our flow or our volume time loops down here, curves down here, a good long exhalation. When you reach your peak volume, that again is your forced vital capacity. And then if this is volume and this is time, this is 1 second. So if we go backwards, that's our FEV1. So you can get the same information that's provided in this table by looking at the volume time curves. And then with respect to the flow volume loops, the same thing. The end of flow is your forced vital capacity. They add a little extra box in here which shows you what your FEV1 is. And then the slope of this line, which is FEF 25, 50, and 75, the slope of this line, FEF 25, 75, is small airway function, which is effort and technique independent to some extent. In addition, on our reports, you see all of the forced expiratory movers that were performed. This information is transcribed directly into the front page of the reports. But again, I'm sort of old-fashioned and like to see FEF 2575 because most of the diseases we're interested in start in the small airways, and you can have normal percent predicteds for FVC and FEV1. Typically with a decreased ratio, but you can have very disproportionate small airway disease compared to large airway disease. So I think it's always instructive to look at the FEF 2575 as well. The other thing we include in our reports are these trend studies, and this is spirometry done in this individual from January of 2019 through December of 2021, and it shows exactly what we would expect, which is a gradual increase in FVC and FEV1 in a growing child. Most of the time we see something pretty similar to this, but there are progressive disease processes where you actually see a plateau or even drops in lung function in growing kids, which is really kind of ominous. We also see any pre-post testing. This particular child, every time they came in, they had what was considered poor baseline lung function, and every time he or she was seen, they had very robust bronchodilator responses with significant improvements in FEV1 and FVC, most notably in FEV1 compared to FVC. And I will tell you, if we put FEF 2575 on here, we'd probably see even bigger pre-post changes on that figure. And this is another example of one of these trend studies looking at percent predicteds. There had been relative stability here and then a significant improvement, which was sustained over time, sort of indicating that some therapy was started there. Something happened that improved lung function over time. So I think these are really important to look at as well in growing kids. Couple of patterns that are worth knowing about with respect to these flow volume loops. Again, this one is normal. With restrictive disease, everything is just smaller than it's supposed to be. With obstructive disease, we talk about scooping or concavity here during the expiratory. The truth is, people have looked at these objectively, and the degree of severity based on eyeballing this between observers is really pretty bad. So you can't really say a whole lot about degree of obstruction based on these curves alone, but it's a typical pattern for an obstructive process. This particular curve where you see boxed off inspiratory and expiratory flow is suggestive of some type of fixed intrathoracic or perhaps extrathoracic lesion, although intrathoracic it's much more common. You can see this with vocal cord paralysis, mediastinal masses due to Hodgkin's lymphoma or adenopathy secondary to TB, but you have fixed obstruction that involves both inhalation and exhalation. With this one, we have a normal inspiratory loop with a flattened expiratory loop, which suggests intrathoracic variable obstruction. We see this type of process with severe airway malacia, whereas patients start to exhale forcefully. If they have cartilage problems, either inherently or congenital due to cartilage malformations or acquired problems, the airways become overly collapsible from lack of cartilage support, and you have expiratory flow limitation. And then we're seeing more and more of this type of pattern where you've got normal exhalation, but inspiratory limitation where individuals can't get air in. And we're seeing lots more functional respiratory disorders like vocal cord dysfunction, where you will see this type of pattern where individuals can exhale just fine but can't get air in. So those are worth remembering. I said I was going to talk a little bit about pre-post spirometry, and the important thing here is that the rules have changed. And we're now looking for a 10% change, looking at relative changes compared to baseline, as opposed to the 12.5% change, just looking at pre and post FEV1. So that should be something that's automatically calculated in your reports by your pulmonary laboratory, but it's good to confirm that. So the purpose of pre-post spirometry are several. A lot of times I will go ahead and get pre-post spirometry the first time I see kids, particularly if there's any question about whether or not they have obstruction. If you've got a child that's 90-some% predicted for their FVC, do they have some baseline obstruction, and after bronchodilator they're actually 120%? It's certainly possible. So during those initial evaluations, it may be helpful to do pre-post just to ensure what the patient's actual baseline is. Anytime there's an acute illness, whether it's an asthma exacerbation or a CF pulmonary exacerbation, I think it's worthwhile to do pre-post to look for airway reversibility. And then, of course, as the students like to tell me, that change in pre-post bronchodilator spirometry is not absolutely necessary, but certainly helpful to diagnose asthma. So this is a typical pre-post report that we generate here. This is baseline information as I just went through. Again, you see pretty steep drop-offs between FVC and FEV1. And as a result, that ratio, and again, it's not the ratio of the percent predicted, it's the ratio of the actual numbers of 57%. So fairly significant obstruction. And again, you can classify it based on the Z-score or the percent predicted if you're old-fashioned. We repeat everything after the bronchodilator, and we report the absolute change in milliliters as well as the percent changes. So very significant response here with a 45% change in FEV1. And again, to sort of harp on FEF 2575, if we looked at those numbers, they could be a lot higher than this 45%. I've seen people that increase their FEF 2575 200% during acute illnesses. Same information provided in graphical form. Again, green is good, red is bad, and we improved to green for FEV1 and got pretty close to our 80% cutoff for the ratio of FEV1 to FVC. And then finally looking at the flow volume loops, again, very scooped, maybe not so scooped, but it'd be hard to say a whole lot based on just the shape of those curves. So just want to talk about bronchoprovocation really quickly. I'm not sure how often you guys are really doing that, other than probably a lot more in the adult world for the environmental and work-related evaluations. I don't do a whole lot of methacholine in kids. We do a lot of exercise challenges, though. Again, the pre-post is done for evaluation of exercise-induced asthma or bronchospasm. There are, again, standards from the ATS, ERS, and 10% decrease from baseline is what's considered abnormal for exercise testing, although there's some literature that says 15% is more specific, but that's not standard yet. So here's a typical exercise report at Children's Mercy. You've got your predicted values, baseline values, run for 5 minutes, after 10 minutes, and then at the conclusion of the study, you do a bronchodilator. Lots of numbers on here that can kind of make your head hurt a little bit. So I think these are actually more helpful. So this is baseline, this is 5 minutes, this is 10 minutes, and then after the bronchodilator is given, and this is actual values versus percent predicted. So you can see a pretty steep drop-off in this, and this was actually a positive exercise test with, again, significant decreases. Methacholine challenge, again, don't do them very often. The methodology behind them is that you use increasing doses / concentrations of methacholine given over a specified period of time. And there are standard protocols from the ATS ERS. So what we're looking for here is a 20% drop in FEV1, which is indicative of significant airway hyperresponsiveness. And I tend to harp on people about using the word hyperresponsiveness as opposed to reactivity. I've not yelled at, but gently redirected countless students, residents, fellows about using reactive airway disease, which is a term that I absolutely hate and despise. Airway hyperresponsiveness is one thing. There's no such thing as airway reactivity. We look at the PC20, which is the concentration at which there's a 20% drop, and the PD20, which is the dose at which there's a 20% drop in FEV1. So these are the standard reports here. They've got, again, the increase in concentration / dose of the methacholine. They've got change in FEV1 from baseline. We include the definitions of normal, borderline, mild, moderate, and marked hyperresponsiveness here because nobody can remember them. And again, the graph is really helpful. They give you the 20% drop here. And if your FEV1s don't drop below the line, you've got a normal study. Got a few minutes left. I'm not going to talk much about lung volume measurements. We do it a lot in pulmonary. I don't know that you guys do it at all in allergy clinics. Chris or Sal or somebody, do you guys ever do this?
It would be extremely rare.
Yeah. Two methods that are done. Helium dilution, which is the original method. It's really not done much anymore because it's not as reliable as plethysmography. Don't even attempt to think about this because this too will make your head hurt, but we basically lock kids in a plastic box and make them try and breathe against a shutter and measure changes in volume in this box and pressures. And the important thing is down here, it allows us to measure residual volume and therefore calculate total lung capacity, which is important. And this is a standard lung volume by plethysmography report. And again, the important information that's not otherwise available is the total lung capacity given in Z-scores as well as percent predicted. And then the residual volumes are down here. So these all look pretty normal. Diffusion capacity, I think we can skip. We use it again a fair amount. Other really exciting things that get me going as a pulmonologist, this alveolar gas equation, which we use to calculate the partial pressure of oxygen in the alveoli. It's important, mostly in the ICU when you're looking at patients' arterial oxygen tension versus the alveolar oxygen tension, which allows you to calculate the AA gradient, which is a very sensitive indicator of severity of lung disease. Oxygen carrying capacity is something that's really important to us. Something that I love are these Davenport diagrams, which I use on a regular basis to assess acid-base balance. Is everybody having flashbacks to physiology class? You should be at this point. Oxygen dissociation curve is something we use all the time, and then we've got all sorts of other exotic stuff we do in pulmonary medicine. So these references with all these ATS ERS guidelines are here. So that's it for things I wanted to talk about.